Good afternoon, everyone. Welcome to this webinar entitled Sport Ultrasound of the Forefoot, presented by Dr. Douglas Hoffman. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to formulate a sonographic approach to forefoot pain and recognize the common pathologies associated with metatarsalgia and forefoot pain. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Doug Hoffman and Darcy Belito de Luna have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Douglas Hoffman.
All right, so good afternoon, I guess good morning if you're on the West Coast. My name is Doug Hoffman. I reside in Duluth, Minnesota, northern Minnesota, where it's been snowing the last couple days. I'm in both departments of radiology and orthopedics, and I'm the director of musculoskeletal ultrasound in a large medical system, so we have a very busy MSK ultrasound practice. In our medical group, we also have a very robust foot and ankle program, which in turn has pushed me to advance our diagnostic capabilities in foot and ankle disorders. And today we're just going to focus on the forefoot. I do not have any disclosures. And I'm going to touch on 3 areas today. I'm going to briefly talk about using ultrasound to diagnose early metatarsal stress fractures, but the majority of time is going to be spent on the first metatarsal joint and then the lesser metatarsal joints, and particularly in sorting out the etiology of metatarsalgia. And just a couple of general comments before we jump into it. The first comment is, and I usually do this with all my talks, is that radiographs are prerequisite in our institution before we start a sonographic evaluation of the forefoot. Radiographs are both essential and complementary to the sonographic evaluation. Radiographs allow us to look at deformities, which are important. They allow us to look at bone lesions, sometimes get a more global appearance of the joint. So again, if a patient doesn't have radiographs of the foot prior to the sonographic evaluation, we have a standing order to obtain them. I'm a strong proponent of protocol-based evaluations, so we're not missing any pathology. And my protocol for the forefoot is really quite simple. I start on the dorsal aspect of the foot, and we'll start on the metatarsals if clinically indicated. Otherwise, I'll start on the joints, and then I'll move over to the interspaces. And once I finish that dorsally, I go to the plantar aspect of the foot, where I start with the plantar plates, move over to the interspaces, so I'm evaluating interspaces both dorsally and plantarly, and then I scrutinize the fat pad. Asymptomatic abnormalities are common in the forefoot, and so it's important to correlate abnormalities that you may find on the sonographic evaluation with the patient's history and physical exam, as well as sonopalpatory pain. So it's not unusual for me to put in my report let's say if I see a neuroma within the second interspace, I'll say this is the maximal area of tenderness with sonopalpation. Or, for example, plantar plate tears are common in the fourth Mtp joint and asymptomatic. I'll just say, there's no pain at the site with sonopalpation to direct a clinician regarding the sonographic findings. Okay, so we'll just jump right into it. And as I mentioned, we'll start with just use of sonography to assess for metatarsal stress fractures. And it really is most useful in the very early stages of metatarsal pain before radiographs reveal abnormalities that might suggest a stress fracture. So here's a 27-year-old runner who has second Mtp joint pain and normal radiographs. And he's had pain for 3 to 4 days. And normally, we do not see the periosteum on sonography. It's so thin and close to the cortex that it's not imaged well. And here you see it on the contralateral side, the normal echogenic contour of the bony cortex. But if we go to the symptomatic side, we see right at the metatarsal neck thickening, hypoechoic thickening adjacent to the cortex, which is periosteal thickening. We see adjacent edema, and with Doppler activity, we see blood flow. And so those are the three main findings that we see with a very early stress fracture: periosteal thickening, hypervascularity, and adjacent edema. Here's a companion case of a 21-year-old runner with midshaft third metatarsal pain. And again, we see segmental hypoechoic thickening adjacent to the cortex, which is periosteal thickening. It's associated with hypervascularity. And on short axis image, we see surrounding edema. And again, this is before there are radiographic changes. So sonography really is quite useful and fairly accurate for early stress fractures before radiographic changes. I also find it useful for proximal metatarsal stress fractures where radiographs may hide the stress fracture throughout its course. So we're going to jump into the first Mtp joint, and I find that ultrasound to be very helpful in sorting out the etiology of pain of the first Mtp joint. And again, radiographs are very important in this regard. The most common diagnosis we see of the first Mtp joint is osteoarthritis, but we also want to distinguish that from urate deposition disease. Certainly we see sesamoid abnormalities, injury to the plantar capsular ligamentous complex, or the so-called turf toe, and then rarely you can get dorsal capsular injuries. So the sonographic findings of osteoarthritis are bony hypertrophic changes, usually in the form of dorsal osteophytes, both from the proximal phalanx and from the metatarsal head. Generally there's synovial hypertrophy and mild or no hypervascularity. So in other words, you can get a mild synovitis associated with osteoarthritis, but generally there's not a robust synovitis associated with this. So here we see again bony hypertrophic changes dorsally. We see joint space narrowing or loss, and we see that there's really no associated hypervascularity with the synovial hypertrophy. So these are typical findings. But it's important to be able to distinguish these findings from that of urate deposition disease. So again, we correlate with the radiograph, and as you know, the most common radiographic finding in gout is a normal radiograph or periarticular edema. Certainly in later stages, we can see the typical skip lesions associated with gout, which would not be revealed very well on sonography. But in contrast to osteoarthritis, urate deposition disease, we see these hyperechoic aggregates within the joint capsule. And these can take the form of these, what's called these aggregates, or sometimes they're more just echogenic dots within the synovium, or the snowstorm appearance. And these aggregates are urate deposition. The other common finding is that of the double contour sign. And what that is that urate deposition has a predilection for depositing on the superficial portion of the articular cartilage. And that's in contrast to calcium pyrophosphate crystals, which tend to deposit throughout the thickness of the hyaline cartilage. So it doesn't give you a double contrast sign, but it does make the whole thickness of the hyaline cartilage more echogenic. But in urate deposition, we get this double contrast or double contour sign, excuse me. And then the other feature is that we tend to get more of a synovitis. So here's a patient who has this kind of chronic first MTP joint pain. This is not an acute flare of gout, but we see already that this person has hypervascularity of the synovium, indicating a higher degree of inflammation. Now, it's important to be able to distinguish the double contour sign from a common artifact termed the cartilage interface artifact. And what this artifact is fluid adjacent to the hyaline cartilage, given a little echogenic or a very thin echogenic rim on the hyaline cartilage. And this is distinguished from the double contour sign in that when there's a shift of fluid, this echogenic rim changes location. So in this particular person, as I'm moving the transducer, you can see that echogenic rim changes, wherein if this was urate deposition, movement or fluid shifts would not change the double contour appearance. Okay, so moving plantarly, we're going to go over some of the basic anatomy of the plantar aspect of the first MTP joint. And so we're going to start with the sesamoid and lateral and medial sesamoids, which is also the attachment of the flexor digitorum brevis, two heads of the flexor digitorum brevis. And in between the two sesamoids runs the flexor hallucis longus tendon as it travels to the distal phalanx. So here we see a cross-section, anatomic cross-section, and we see the metatarsal head, we see the two sesamoids, and we see the FHL right in the middle. There's a ligament that traverses between the two sesamoids termed the intersesamoid ligament, which we can see here. Beneath the intersesamoid ligament, we have the plantar plate, which has several components to it in the first MTP joint. First, we have the main body of the plantar plate between the sesamoids, but as we slide medially or laterally, there is a sesamoid phalangeal ligament, which is part of the plantar plate. So in this sagittal cross-section, we see the sesamoid, and then we see a ligament attaching to the proximal phalanx, which is the sesamoid phalangeal ligament. And so this is a sonogram, and I'm on the main body of the plantar plate right here. And what I'm going to do is first slide to one direction to the sesamoid and then slide to the other direction, and we can see the entirety of the plantar plate. So this is a sesamoid phalangeal ligament, and I slide back to the middle, and I'm going to slide over to the other side, and again, we see the other side of the sesamoid phalangeal ligament, making the entire width of the plantar plate. All right, going over further sonal anatomy of the plantar aspect of the first MTP joints. First, we see the sesamoids, again, well visualized on sonography, and we see the echogenic cortex of the sesamoids. You can see it both in short and long axis. And we see the FHL, which forms the apex of this complex when looked from the plantar surface. So it's well visualized both short and long axis, and it covers the body of the plantar plate. We easily can evaluate the insertion of the flexor hallucis brevis muscle tendon unit onto the plantar aspect of the sesamoids, both in long and short axis. And then the body of the plantar plate, which I showed you in that video, and we see that it has a robust attachment onto the volar base of the proximal phalanx. And then again, we can see the sesamoid phalangeal ligament. And we always want to evaluate the plantar plate in orthogonal view, so we see this in short axis. And so in short axis, this is the deepest structure that's then just plantar to the MTP joint. And the structure that's just above the plantar plate is the intersesamoid ligament. So we have FHL, intersesamoid ligament, and plantar plate. Ultrasound is fairly good for evaluating sesamoid abnormalities, particularly if they're non-acute. So this is a case of a 34-year-old runner who has medial sesamoid pain, and we can see on radiographs that there's a bipartite medial sesamoid. However, when we look at sonography, we see that it's not just bipartite, heart type, but it's fairly fragmented and irregular, underappreciated on radiograph. And with Doppler imaging, we see that there's hypervascularity, there is surrounding edema, and this would be typical of sesamoiditis, which is our term really used for pain due to repetitive microtrauma rather than true inflammation. This is a 16-year-old hockey player who has lateral sesamoid pain. And we see a different variation of this so-called sesamoiditis, where this is more of an enthesiopathy at the insertion of the flexor hiatus brevis tendon onto the sesamoid. So we see hypoechoic thickening of the tendinous insertion, a little bit of surrounding edema and hypervascularity, and again, confirmation with sonopalpatory pain. This person did well when modifying her hockey skates to unload the area. Osteonecrosis and the stress or an acute fracture are also causes of sesamoid pain, which ultrasound really does not evaluate well. So in the case where I'm suspicious for osteonecrosis or I'm worried about a true stress fracture or an acute fracture, I typically go to an MR or CT scan in the case of an acute fracture. Okay, so injury to the plantar capsular ligaments complex is not a common injury, but can result in quite a bit of morbidity to the athlete when this does occur. The most common pathology associated with the so-called turf toe is a plantar plate tear. And as you know, it's a hyperdorsiflexion injury. And sonography really evaluates most of these structures quite well and may eliminate the need for MR in this case. So this is a case of a typical plantar plate rupture. So we see on a long axis image here, this essentially stub of the plantar plate and the flexor hiatus longus tendon has now moved dorsally against the metatarsal head and surrounding edema. On short axis, we see the FHL tendon directly against the metatarsal. And just for comparison, typically the plantar plate is going to interpose between the FHL and the metatarsal. And we see the MRI correlate of this both in long and short axis. This was actually a recent case I had just a couple weeks ago, so I threw this in, and this was a 51-year-old patient who was going up and down the ladder putting on Christmas decorations and felt a slight tearing sensation going down the rung and has had pain in that area since that time. And so again, we approach in a protocol based exam starting with the joint, and so I start dorsally with the first Mtp joint, and we see that there is thickening and fluid within the joint. Here with a little movement and compression, we can see the synovial thickening and some fluid. Now you could argue maybe there's a hyperechoic aggregate in there, but I think that's really just all synovial thickening. But I just want to point out that fluid within the first Mtp joint, as well as the lesser Mtp joints, is very common and should be evaluated with caution. So here we see the same patient, and I just take a comparative contralateral view of the first Mtp joint, which is completely asymptomatic, and you can see there's a little bit of synovial hypertrophy and a fluid within that joint as well. But clearly there's some synovitis going on there. Then we're going to move plantarly, and we see a tear in the plantar plate. There's a hypoechoic defect right there, and we're going to do a dynamic study where we gently move the great toe and plantar flexion dorsiflexion. And this is really a full thickness tear. And how do I know that? Well, I can see there tracking up through, but also there's a little bit of fluid on the other side of the FHL. And so when you see fluid adjacent to the proximal phalanx or adjacent to the flexor tendons, then it's most likely you have a full thickness tear. And here we see this on the short axis view. So remember, we have those three layers. So the first layer closer to the end would be the plantar plate, and we see a defect there. And the second layer would be the intersesamoid ligament, which is intact, and then we have the FHL, which in this view has some anisotropy. This is an uncommon injury. I've only seen one or two of these, but this is a dorsal capsule injury of the first Mtp joint. This was a 15-year-old gymnast that landed awkwardly from a dismount, had a hyperplanar flexion injury, and this was actually 4 or 5 months prior to the sonographic evaluation. And we can see that there is hypoechoic thickening of the dorsal capsule, and we see on this long axis view there's a small bony fleck, avulsion, from the proximal phalanx. On short axis views, we see a similar appearance to the cortex of the first metatarsal head, and as comparative view, you can see that there is persistent hypertrophy and thickening of the dorsal capsule. And then this is a case of one of those probably never see again, and I have to say, as my teenagers would say, really? So this is a 26-year-old marathon runner who was referred for an ultrasound due to persistent and fairly severe plantar first Mtp joint pain. And the history goes that he's a marathon runner, and he went to a running store to get new shoes, and they put him on this evaluation of their gait and contact area, and said, well, you need anti-pronation shoes to prevent injury. Of course, he hadn't had an injury at that point. And so he bought these $200 anti-pronation shoes and started running, and then when he increased his mileage, he started having pretty focal plantar first Mtp joint pain. But because they were $200 and he couldn't afford another pair of shoes, he was just going to run through it to the point where he couldn't run anymore. And you can see on the short axis view, we see the sesamoids and the FHL. There's fluid circumventing the sesamoids. The sesamoid ligament is intact, but you can see with some compression, there is fraying and longitudinal tears of the FHL. So in summary of the first Mtp joint, most commonly we see osteoarthritis, well evaluated by ultrasound in conjunction with correlative radiographs. In my opinion, ultrasound has been a game changer for urate deposition disease, not only able to diagnose it without necessarily seeing crystals with classic findings, but also to be able to aspirate small effusions in acute gout and therefore definitively diagnose the presence of urate crystals. Sonography is pretty good for evaluating sesamoid abnormalities, particularly with repetitive microtrauma to the area. It's very good for evaluating plantar capsular ligament injuries or the turf toes. All right, and so we're going to move on to the lesser Mtp joints. So when I started in the musculoskeletal program at our institution, I kept a record and still do of every diagnostic exam. So in a talk like this, I go back to my Excel spreadsheet and I put in forefoot and metatarsalgia. And starting in 2013, I've done 559 forefoot exams, diagnostic exams for metatarsalgia, which is 6% of the total number of diagnostics ultrasound I've done to this point. And I also pulled the diagnoses, and it was interesting that 3 diagnoses emerge as the most common causes of lesser metatarsalgia. And so the first is an interdigital neuroma, or the so-called Morton's neuroma. The second is plantar plate abnormalities. And then the third is abnormalities to the fat pad. So I thought that was interesting. Certainly these are all part of our protocol when evaluating metatarsalgia and lesser Mtp joint abnormalities. And again, the protocol, I almost always start with the joint, dorsally, and then the interspace, and then I go plantarly, where I evaluate the plantar plates and plantar aspect of the Mtp joints, go back to the interspaces, and then scrutinize the plantar fat pad. So let's go through this. We'll start with dorsally and the joint, and I see several interesting abnormalities of the joint with metatarsalgia, and to me the most interesting is this osteoarthrosis or capsular hypertrophy, and it takes a different form than typical osteoarthrosis, and we'll go through that. Certainly you can see a true synovitis, particularly with an inflammatory arthropathy, and also a less common cause is the osteonecrosis, or in the teenager, the Freiberg's infarction. So small effusions are common of the Mtp joints, including the lesser Mtp joints, and I don't get too excited when I see a small effusion. Hammer toe deformities are an age-related finding and very common with metatarsalgia. And when evaluating the joint, it's very important to include short axis images. People forget about the short axis images, and I'm going to show you why including those is important. So here's a 23-year-old ballet dancer who has second Mtp joint pain. And here's a long axis image, and we see that there's some irregularity of both the proximal phalanx as well as the metatarsal side of the joint, but really there's not a lot of what I would say capsular hypertrophy that's appreciated on this. But when we go to the short axis image, right away we see there's a fair amount of capsular hypertrophy. And notice that this capsular hypertrophy is mixed echogenic, meaning it's both hyper and hypoechoic. It's not just strictly hypoechoic. And then we go to a similar case in a 43-year-old runner with second interspace pain. And this person was actually referred to evaluate a Morton's neuroma and already scheduled for surgery for a neuroma removal. And again, on long axis imaging, we see some capsular or joint hypertrophy with mild hypervascularity. But when we go to the short axis image, it's fairly impressive. We can see why this person has interspace pain, because the capsular hypertrophy is fairly circumferential and takes up most of the interspace. And this person did not have a neuroma within the interspace. And so capsular hypertrophy can mimic a Morton's neuroma in terms of pain. And again, I want to bring your attention to the fact that this is not hypoechoic, but is really in this case hyperechoic, or the same echogenicity as the surrounding subcutaneous tissue. And this is just a comparative side. And you can see the irregularity associated with the metatarsal head and this degenerative process here. So osteoarthrosis or capsular thickening is most common in the second Mtp joint, as I've found from my series. Capsular hypertrophy is much greater than synovial hypertrophy in these cases. You can get both joint and interspace pain, in this case mimicking a neuroma, and is best visualized on short axis images. So short axis images are part of our protocol in the forefoot exam of the joints. I want to contrast this with true synovitis. So this is a patient with rheumatoid arthritis, and you can see that the synovium in this patient is much more boggy, less distinct. It's predominantly hypoechoic and associated with diffuse hypervascularity. And now you see erosions rather than just cortical irregularity. So this is in distinction to the capsular hypertrophy that we see. Okay, so we're going to move over to the interspace and go through the anatomy of the interspace, which is important for assessing for interdigital neuromas. So we're going to start with the dorsal intermetatarsal ligaments. It's a fairly robust ligament that divides the interspace into a dorsal and plantar compartment. Dorsally, the main structure is the bursa. We see the interosseous tendons on each side of it that are not well visualized on sonography. And so we can see not only in long view here, but on sonography we can see in short axis the intermetatarsal ligament. Actually, we don't see it well in sonography on long axis, but we do see it on short axis. I mentioned dorsally we have the intermetatarsal bursa, again above the ligament, fills the interspace. And then if we go below the ligament into plantar compartment, the digital nerve resides. And in this dissection here, I was somewhat surprised, I don't know why, but I was somewhat surprised to discover how plantar the interdigital nerve is. And so you can see in this dissection, as soon as you peel away the plantar fat pad, there's a nerve right there. In fact, this person has a small neuroma in the third metatarsal interspace. And you can see that the nerve, again, is in the plantar compartment. And so again, I'm surprised once I did the dissection how plantar of a structure that this was. And then finally the inferior metatarsal ligament, which is really almost a very thick fascia of which the plantar fat pad adheres to. So it's not really a true ligament. And so evaluating the interspace dorsally, we can see sonographically that we can see many of these structures. So the interdigital nerve, and this is with some pressure plantarly with the thumb that I'll go over in the next slide, but we see here is the interdigital nerve, and to the left is distal and to the right is proximal. And we see that the triangular arrows outline the nerve, which come down and go right under the intermetatarsal ligament. So this ovoid structure, hyperechoic structure, is a short axis image of the intermetatarsal ligament. Above the intermetatarsal ligament is the bursa, and then you can see the continuation proximally of the interdigital nerve. So again, nerve, ligament, and bursa. So let's talk about interdigital neuromas. They're common in the asymptomatic population. In fact, 50% of people in an asymptomatic population are discovered to have neuromas. So again, it's important to confirm the sonographic findings with the patient's symptoms. Studies comparing to MR show equal sensitivity. And I would say, I personally believe that small neuromas are more sensitively discovered by ultrasound than MR. Again, we can do dynamic studies. We can see very small thickenings quite well with sonography. Concurrent bursopathies are ubiquitous in neuromas, leading to the term the neuroma bursal complex. So this is an article that came out in Journal of Ultrasound Medicine in 2016, a group in Hospital for Special Surgery in New York, where they compared these sonographic findings with surgery and histopathology, showing that what we're really seeing is a neuroma bursal complex. So in this case, we think we see a fairly good distinction between the bursa and the neuroma, but it turns out that even what we think is just neuroma is also some bursal tissue that's wrapping around it. And so I've actually gotten away from calling these neuromas, but I call them neuroma bursal complexes. I've had several patients have neuromas removed that have the classic ultrasound appearance of neuroma, and it was primarily bursal tissue. And you can take a dorsal or plantar approach to imaging, which I'll go through. So we'll start with the dorsal approach of the inner space to evaluate for neuromas. What's the advantage of the dorsal approach? Dorsal approach is better echogenicity. The skin is thinner on the top of the foot than it is on the bottom of the foot, fairly accessible. In my opinion, it's a more complete evaluation of the inner space. So not only are we able to see the nerve, which is in the plantar compartment, but we can see all the structures in the dorsal compartment, primarily the bursa. However, it is more difficult. There's a feel to doing this. And so here's how I do my dorsal exam. And so I have the patient relax their ankle, relax their foot, and I push directly under the web space with my thumb. And what that does is separate the metatarsals and pushes up on the interdigital nerve to make it more accessible to the echoes. And then you can use a hockey stick or just a fairly thin footprint linear array transducer works just fine. This is actually using this linear array transducer right here. But it is more difficult, so there is a feel to it, and it can be quite difficult when the inner space is narrow or they have advanced hammer toe deformities. And so it does have some limitations, and again, there is a learning curve. But when you push up with the thumb back and forth, you can delineate the margin where the nerve traverses. So in this case, the nerve traverses, goes right through this area and back up. You can see the intermetatarsal bursa, and you can see a small neuroma here. There's actually fluid in the bursa. So this is the typical appearance that I do when I'm evaluating dorsally the inner space. Now, plantarly is an easier exam. You can also see the molars click quite well when there is one present, again, confirming the presence of a neuroma. However, the plantar skin is much thicker. Sometimes echogenicity is compromised. And you also get an incomplete evaluation of the inner space because you're not assessing the dorsal structures. But you know, my feeling is we should do both. So plantarly, it's really quite easy. We lay it in and most commonly a short axis position right in the inner space, and a gentle pressure in the transverse arch of the foot, a gentle compression. So here we see short axis image and gentle compression, and we see a neuroma, again, a very plantar structure, pop in and out of the inner space. This is a long axis image, plantarly, of a large neuroma bursal complex. And then again, we mentioned that we can see the molars click, and here we see a nice molars click. And we have to remind ourselves that this is uncomfortable to patients, because I can sit here all day and keep looking at this. The patient has to remind me, did you get what you need? Because it's so cool. So the bottom line for me is that you should become proficient at both the dorsal and plantar approach in assessing for neuromas. They're complementary and confirmatory, and you're going to get a complete evaluation by mastering both. Ultrasound can also be used to guide injections into the neuroma. So typically when I do an injection into the neuroma bursal complex, I am doing a distal to proximal long axis implant approach. So I go in at the dorsal aspect of the web space and straight down into the middle of the neuroma and inject directly into the neuroma. And not only does the neuroma seem to, in a sense, blow apart a little bit, but you fill up the intermetatarsal bursa in this case. Ultrasound-guided procedures have also been described and efficacious with neuromas, including alcohol injections. And there's some evidence that ultrasound-guided alcohol injections are much more efficacious than clinically guided injections, radiofrequency ablation, and cryoablation. Details of this are beyond the scope of this talk, but just to mention that they exist. Their efficacy has been comparable with surgery, and if you see a lot of neuromas, it's worth looking into. Related to the neuroma in the inner space is the bursopathy, and so we again mentioned that the most common cause of an interdigital bursopathy is the presence of an interdigital neuroma. The process is not well understood of what causes neuroma, but whatever is forces are causing the nerve to undergo fibrosis, mucinoid degeneration, also seem to be affecting the bursa. So again, this is a neuroma, and we see fluid within the bursa associated with the neuroma. This is a patient with rheumatoid arthritis who has a large intermetatarsal bursa, and you can see it fills up most of the inner space. And if we look on short axis, we see again that it fills up the majority of the inner space. And notice that again it fills dorsally, and this would be underappreciated when just looking from the plantar aspect. So this is looking from the plantar aspect in this patient. We see there's large hypoechoic masses in both inner spaces, and we're not really sure if this is a neuroma or is this an intermetatarsal bursopathy, but by looking dorsally and filling up the inner space in the setting of rheumatoid arthritis, this would be very typical of a rheumatoid intermetatarsal bursopathy. Okay, so we're going to move to the plantar plate of the lesser Mtp joints. And plantar plate is a dense fibrocartilaginous structure and therefore hyperechoic. It does not have a firm attachment to the metatarsal, but a very firm attachment to the base of the proximal phalanx, which is also where the pathology occurs. And so when we're scrutinizing the plantar plate with ultrasound, this is what we want to focus on. We want to focus on the distal third of the plantar plate and its insertion on to the volar base of the proximal phalanx. Notice that there's a little hyperechoic triangular part of this attachment, and that's normal. And what that is, if we go to this histopathology section here, this is articular cartilage of the proximal phalanx. This is the bone, and this is the attachment of the plantar plate, so this would be flipped as compared to this image. And this white structure is all fibrous interdigitations that reinforce the plantar plate's attachment onto the bone hyaline cartilage complex. And that's what this is, given that hyperechoic appearance. So again, this is a normal finding of the attachment of the plantar plate. So again, we discussed that Attachments are strongest onto the proximal phalanx, which is where the pathology is. And remember that not only are we looking longitudinally, but we need to understand that there's a width to the plantar plate, so we're also going to scrutinize in short axis. And most of the pathology, although not all of it, but most of the pathology will start laterally, particularly of the second plantar plate. And so when we evaluate the plantar plate sonographically, I typically start with the long axis image. You want to be careful of anisoptropy because it has a convex morphology to it, so it's easy to see increased hypoechogenicity in this area due to anisoptropy, and so make sure you angle your probe to account for that. As I mentioned, we want to scrutinize the full width of the plantar plate, and I always do dynamic evaluations when I see pathology. In short axis, we want to make sure we follow the plantar plate to its insertion onto the proximal phalanx, and particularly the lateral condyle, and I'll talk about that in a second. Sonography has been shown to be equal to that of MR for plantar plate tears. Again, when you look at these studies, these are special coils that are being used for the toe. I know our institution doesn't have these coils, even though we're quite large. So again, I would submit that the sonography of this is really quite accurate. And so here we see in long axis the plantar plate and dynamic evaluation. Again, you can see how easily we can get anisoptropy in this area. Here's that little hyperechoic triangle we talked about. Overlying the plantar plate is the flexor tendon. On short axis, we see the flexor tendon and then the plantar plate interpose between the flexor tendon and the metatarsal head, or the proximal, or the metatarsal head in this case. And we want to again scan distally until we see the two condyles of the proximal phalanx. There can be pathology that's easily missed in this area that can be clinically relevant. So plantar plate tears are most commonly attritional and rarely acute, and tend to be progressive. As I mentioned, they often are associated with hammer toe deformities, and the progression is from a partial thickness tear to a full thickness tear that can go on to joint instability. So here's a 46-year-old football coach, and we see here that there is a partial thickness tear to plantar plate. On short axis, we can see a partial thickness tear, and we follow that out to the condyle. This is lateral condyle. Lateral condyle is often more plantarly located than the medial condyle, and it looks normal. There's no irregularity. This person was asymptomatic, and again, we need to interpret these in the context of the patient's symptoms. On the other hand, this is a 62-year-old daily walker who has pain directly beneath the second Mtp joint, and we see again a partial thickness tear, a larger partial thickness tear. We can see that on short axis imaging. This is lateral, this is medial, and I would actually argue this is a focal full thickness tear in the sense that I'm seeing fluid on the other side of the flexor tendon. But what's important in this is that we follow this out to the lateral condyle, and this is lateral to the right, and we see bony fragmentation and a little bony projection in surrounding edema. And this was the maximal site of tenderness with sonopalpation. So it's not only a plantar plate tear, and you can see that it's really underestimated on the long axis images, but this was focally tender to sonopalpation. Here's some examples of some full thickness tears. Here we have on long axis here, and we see fluid. We see fluid on the other side of the tendon, which is confirmatory. This patient, again, a different patient, a full thickness tear, fluid outside, again confirming that it's going straight through from the joint to the subcutaneous tissue. In this patient, there's been some retraction of the full thickness tear with herniation of the flexor tendon into the gap. This is a 26-year-old who had a hyperplantar flexion injury playing beach soccer. Both the third and fourth toes were dislocated and apparently relocated in the emergency room, but he had persistent pain and problems. This person did not come with a radiograph, so this is the radiograph I obtained showing you can see persistent dislocation of the third MCP joint, or MTP, excuse me. So you see that there's a complete rupture of the plantar plate. There's this no echogenic material present, and with the dislocation of the joint itself. Of the fourth, even though it's relocated, you can see that the flexor tendon is directly against the metatarsal head. There is no plantar plate, and this one was able to stay located. Finally, we're going to talk about the fat pad, which goes along either in conjunction with the disorders we've been talking about, but I've also seen a fair amount of fat pad problems in isolation. So again, with someone with a hammer toe deformity, is putting increased pressure, and the only finding that we're seeing is that it's fat pad abnormalities. And so there's two abnormalities I see in the fat pad. The first is this thickening, and it's hypoechoic thickening of the fat pad, and the second is that you can see a discrete submetatarsal bursopathy. And again, it's important to correlate with sonopalpation because these are common asymptomatic findings, particularly age-related. And so plantar fat pad thickening has been correlated histopathologically with fibrosis. And so there was a nice study done on cadavers looking at these findings and correlate them with the histology. So here we see in this live individual here that there is increased fat pad thickening that's concentrated beneath the third and second metatarsals. Notice that the third metatarsal is more plantarly flexed than the second. And if we go long axis on the third, we see again. And it's not in a discrete boundaries that you might see with a bursopathy, but more diffuse. This is often associated with a little bit of hypervascularity. It's unusual to see diffuse hypervascularity. And then you can also see a discrete bursopathy, and this has been correlated with histology as fiber collagen bundles, fibrin-lined papillary projections, which actually look very similar to the sonographic findings here. And with compression, you can see the walls of the bursa. But these, again, can be asymptomatic findings both beneath the first and the fifth. So it's important to correlate this, again, with pain. But I have a number of cases where this is the sole source of the patient's pain, is the submetatarsal bursa. So I thought we'd wrap up the lesser Mtp joints with a case. And this is a 57-year-old female who has moderate obesity, type 2 diabetes mellitus, hypertension, and developed metatarsal pain beneath the second and third Mtp joints when she began a walking program to address her medical problems. Physical exam revealed mild hammer toe deformities and pain beneath the second and third Mtp joints. And she stopped exercising, stopped her walking program because the pain was just too much. So this is a patient where addressing this problem is pretty important when managing your chronic medical problems. And so the sonographic evaluation of this started with the joints, as we mentioned, and this is dorsally, and we see capsular hypertrophy predominantly involving the second, but also the third, not associated with hypervascularity. And I'll just comment that radiographs were minimally abnormal of the second Mtp joint. We can see on the log axis the sense of a little bit of capsular hypertrophy, but this is not an uncommon view in the asymptomatic Mtp joints. So again, just to review, capsular hypertrophy is best appreciated on short axis images. This patient had a second plantar plate tear. All right, so we go plantarly in the same joint, and we see as we go laterally that there is a full thickness plantar plate tear. And I say full thickness because look at the fluid on the other side of the plantar plate next to the proximal phalanx. So this person had a full thickness plantar plate tear. You can see this on short axis as well. So this is laterally, here's the third, here's medially, and the full thickness tear, as I mentioned, is laterally. In addition, this person had a second interspace bursopathy, and so in the interspace, looking dorsally. So again, I'm moving my thumb and delineating the demarcation of the nerve. The nerve seems to come down. It's not really clear if the nerve is thickened or not. So there might be a small neuroma, but we see it right here is the intermetatarsal bursa, and this is all thickened bursal tissue. So I would say this is a predominantly intermetatarsal bursopathy. This may be a small component of an interdigital neuroma as well. but it keeps going. We go to the third interspace, and there we have a neuroma bursal complex, not a large one, but now we follow the nerve. The nerve clearly becomes thickened, and patient is symptomatic there as well. We see on short axis imaging at the third interspace, we see the neuroma pop through. And then finally, there is fat pad thickening. So we have the third Mtp joint here. We see increased hypoechoic thickening of the fat pad, again corresponding to fibrosis. All right, so we're going to end with a couple miscellaneous things. First is a patient that was referred for an injection into the interdigital neuroma in the second metatarsal interspace. So prior to the injection, we look with ultrasound and does not look like a neuroma, but in fact it was a schwannoma. So we get an MRI, and MRI correlate is consistent with the schwannoma, so it's good that this was not injected clinically, and this patient went on to do well after resection. I find ultrasound to be very useful in determining foreign bodies in the foot area, particularly including the forefoot. So this was a 28-year-old patient who 6 weeks earlier stepped on a toothpick in the carpet and had persistent pain. Went to the emergency room, and they said there's no way there's a toothpick in the bottom of your foot. Of course, x-rays are negative. And so she went home and came back a week later, increasing pain, and they again told her there can't be a whole toothpick in your foot. And so finally, she saw primary care, got referred for an ultrasound, and she was quite swollen and beneath the second Mtp joint and the plantar fat pad, and you can see that there's nearly a 4-centimeter toothpick. She was right in her foot, and we were able to take this out with ultrasound guidance with a mini hemostat. And then finally, this is a dorsal foot mass right in the fourth metatarsal interspace, and was referred for sonography to evaluate and characterize. And we see this hypoechoic, fairly well demarcated mass, but an unusual location for a mass. And we can see that it is quite hypervascular. And I was a little stumped when I was doing this, but then on short axis, I scan, and we start here distally. And I see that this mass has a sinus tract going all the way to the web space. So then I open up the web space and I see fairly advanced athlete's foot, tinea pedis, and this is a mass related. This is a sinus tract with tinea pedis, and then a mass full of the fungus. All right, so take-home points, and leaves time for some questions. Reviews radiographs prior to the sonographic evaluation. I do protocol-driven exams. I always take a systemic approach, and I always find things I would miss unless I did this. And again, we talked about correlating the findings with the clinical and sonopalpatory information. And people like to knock Duluth, but this is my commute to work on bike each day along Lake Superior. It's a pretty good place to live, although it's been snowing for 2 days. Okay, so we'll open up for questions. Let me just click on questions here, and I'll click on the first one. The first question is, would injections take place of surgical incision to remove the neuroma? So it's a good question, and the neuroma literature is for surgery is all over the place, from 80 to 90% satisfaction all the way down to 40 to 50%. And so the benchmark really is how do we do with some of these ultrasound guided techniques as compared to surgery. And I would say that that alcohol injections, radiofrequency, and cryoablation, which I'm particularly interested in, compare pretty favorably to surgery. I'm a little more disappointed in a regular corticosteroid injection, and I usually just do a corticosteroid injection if for diagnostic information, for trying to sort out whether it's neuroma that's symptomatic versus, let's say, the plantar plate. But I've rarely found it to be a permanent solution to the problem. Okay, next question. What do you do for the 57-year-old obese diabetic woman for treatment? Good question. And the answer to that question is back to the foot and ankle surgeon who referred her in the first place. But really, that's working with a physical therapist who specializes in foot problems and modifying orthotics, shoes, and such to try to unload that area and see if we can get some symptomatic relief. Certainly, you can do a neuroma resection in a plantar plate tear, but in a diabetic, with all those attritional changes, that would be a last resort. So we've had a fair amount of success with biomechanical alteration, as long as we set the stage that it's not going to be perfect, but it may, allow them to continue exercising again. All right, so next question, how do we treat the plantar plate fractures or tears? Again, good question. Partial thickness tears are very common, and again, I treat those, or they are treated with biomechanical modifications. A full thickness tear, you can do a plantar plate repair. Oftentimes when patients are starting to get instability, that's when you pull the trigger and do a repair, oftentimes with an osteotomy. So it really depends on who it is and what the situation is. Once you do get instability, usually surgical intervention is preferred. Is there a specific size criteria to diagnose a neuroma, or is it based on mostly appearance and tenderness with sonopalpation? So, good question, and I often wonder when I see a little thickening of the nerve, is that really a neuroma, an early neuroma, or is that just a little thickening of the nerve? And I don't know the answer to that. I don't know if anybody does. Obviously, neuromas all start somewhere. And so often when I see some thickening of the nerve, but it's not a discrete neuroma, I'll either say a small neuroma versus, interdigital nerve thickening. And again, some of these are asymptomatic and some of these are tender with sonopalpation. This might be an area where I would consider a corticosteroid injection if there's a very small neuroma or thickening, again, both for diagnostic and therapeutic considerations. All right, next question. Do you use the dorsal intermetatarsal bursa to separate bursal pathology from a neuroma, or do you always bundle the pathology together? No, I do separate it. We saw that patient with rheumatoid arthritis clearly had a bursopathy. And so in those cases, I do just call it an intermetatarsal bursopathy and not a neuroma bursal complex. When I get someone who has more typical pain of a neuroma, may not have an underlying inflammatory arthropathy, then I'm usually calling it a neuroma bursal complex. Again, because I've learned that the pathology is not always concordant with what I'm finding sonographically. So sometimes the nerve is quite big, even though I think there's more bursal tissue, and sometimes it's mostly bursal tissue in a very small neuroma. I think that's all the questions. If there's any more questions.
I've got one more. Let me see. I believe this is referring to an earlier response.
Oh, here we go. Yeah. Would it be done dorsally or via plantar?
And that, I believe, relates to the injections taking the place of surgical incision.
Yeah, thank you. So I always do my injections or procedures dorsally. So plantarly, it's more painful for the patient. At one point, I was trying some alcohol injections, still from the web space, but slightly more plantarly, thinking I could get deeper or more proximal to the nerve. And I had some irritation of the alcohol to the fat pad. So I stopped that very quickly and went back dorsally and make sure I don't get too far plantar if I'm, for example, injecting alcohol. But I just use that same approach when I'm doing any type of injection or procedure to the neuroma bursal complex. We have another question here. Oh, I mean the plantar plate repair. So our surgeons do the plantar plate repair dorsally. Yeah.
Okay. Well, wonderful. Well, thank you very much. And everyone, on behalf of the AIUM and the AMSSM, our thanks to all of you who have participated in today's webinar. Please remember to complete the post-test and the activity evaluation. And we hope you enjoyed this presentation and you'll join us again for future webinars. So long, everyone.